Ventricular rhythms. We're going to be talking about PVCs, the different types of PVCs that you're going to be seeing. Vtac, Vfib, Idioventricular, accelerated idio, and asystole. So just like the PACs, just like the PJCs, we also have PVCs. Except, remember, a PAC is coming from the SA node, a PJC is coming from the AV node, a PVC is coming from the ventricles. Okay, so that's the only difference between the three, where they're coming from. Now it says general rule, the ventricles or Purkinje fibers generate their own electrical impulse, also known as automaticity, but it's a premature contraction. So looking at this, it says the appearance of the PVC will not be standardized as a generated impulse can be from anywhere within those ventricles. And they can vary widely, all right? All three examples of these PVCs are completely different. It states the T wave will display in the opposite direction of the QRS complex. Now that's with regards to the actual PVC itself, okay? So here we see that we have a negative deflection of our QRS complex, but an upright T. Over here we have an upright or positive deflection of the QRS complex, and we have an inverted T wave. That is part of the rules for a PVC. Now there's something here called a compensatory pause. It makes your rhythm look really irregular, but because those ventricles contract at like this awkward time, it kind of delays a cardiac cycle from occurring. Okay, so that's all that's happening here. We get to see, it says, as the beat's premature, this rhythm will appear irregular as there is a pause that occurs after that PVC. So here's some rules. PVCs can generate from any irritable area or foci. Remember, we call it ectopic foci. If the PVCs are occurring and are generated from the same location, this is called unifocal, okay? From the same location. So for example, if I look back at this PVC, or I'll take this one, if this PVC here shows up again in another location, and it's not a pattern, it just shows up, but it looks like identical. The PVC never changes. We call it a unifocal PVC, okay? If the PVCs are occurring and are generated in multiple areas or foci, right, this is considered multifocal. For example, if I took this EKG right here and I put them all together and I see that they're PVCs that are occurring, and they obviously don't look anything alike, they don't look anything like the others, I would call this multifocal PVCs, right? This would be normal sinus rhythm with multifocal PVCs. If the PVC occurs in twos, right? This is two PVCs together. This is considered a couplet. Don't forget that. If you have two PVCs that just beat right after a normal sinus rhythm, you just get two that show up right next to each other, we call that a couplet, okay? It says the more irritable the foci are, the more severe the complexes of the PVCs. And you'll see some crazy looking PVCs. It's just saying that that area of those ventricles are really irritable. So let's take a look at what we got here. First one that we're looking at here is unifocal PVCs. I know I moved that in the wrong spot there. Obviously they look alike. I don't know, some people call them cowboy hats, or what was that? Was that Jesse said that? Yeah, if it looks the same, it's just unifocal. So this would be considered normal sinus rhythm with unifocal PVCs. Let's take a look here. We got one that has an upward deflection, the other one has a downward deflection. Sorry about the arrows, I didn't move them. Because they're both different, we consider that multifocal. All right, we got two PVCs right back to back, considered a couplet. So we would call this normal sinus rhythm with a couplet of PVCs. Okay, now we have what's known as a run. Okay, there's two different names that are typically said: salvos, which is up here, or a run of PVCs. This is whenever you have 3 or more in a row. 3 or more PVCs in a row is considered a run. So here, if we see a run of PVCs, bad news, right? The problem with runs of PVCs, as these heart rates could turn into Vtac, we need to treat these runs. Probably the worst of the PVCs is a run of PVCs. Now, here's another rule. PVCs can occur in patterns. If the PVC occurs every other beat, which means beat PVC, beat PVC, beat PVC, and it continues, this is known as bigeminy. If it is every third beat, meaning beat, beat, PVC, beat, beat, PVC, that is known as trigeminy. And it is now quadgeminy if there are 3 beats in between each PVC. That is known as quadgeminy. And you see exactly how it's written here. EKG diagnosis will be normal sinus rhythm with bigeminy PVCs, or bigeminal. I've seen both written out. Sinus bradycardia with trigeminal PVCs, or trigeminy. Here's some examples. First one that we see is a normal sinus rhythm with a PVC, then normal sinus rhythm with a PVC. We call this bigeminy. All right, every other beat is a PVC, is bigeminal. Down here, middle is trigeminal. We got 2 beats and a PVC. Down here, last one, 3 beats and a PVC is considered quadgeminal. Trust me, I always see students call this one trigeminal and this one bigeminal because they see 2 beats in between. That's not how it works. Okay. And remember, if it's the PVC is the 3rd beat, it's trigeminal. If the PVC is the 4th beat, it's quadgeminal. However you want to memorize that. All right, Colin asks, can runs be unifocal and multifocal? I don't think I've ever seen a run multifocal. They're always unifocal, just like you can see here. All right. We know what the PACs, the PJCs, PVCs, the only difference with the PVC than the others, there's going to be no P wave, because remember, it's coming from the ventricles, and the QRS is going to be wide. Okay. It says wide and bizarre, greater than 0.12 seconds. And remember that T wave is in the opposite direction. All right, Vtac. The ventricles took over, right? Or assumed the dominant pacemaker role. The rhythm is now ventricular in nature. Now, what does it mean for it to be ventricular in nature? Remember, the QRS is going to be wide, right? It's going to be wide and complex. So remember, the term tachycardia does not begin until 100 beats per minute. So a wide, complex rhythm, no P waves, that's above 100, called Vtac. By definition, it's got to be greater than 100, and it's wide and complex. We know it's coming from the ventricles. There's no P waves. It's Vtac. All right. Now, I know some of you are thinking, well, we don't treat Vtac at that rate. All right. Remember, we're not talking about treatment. This is just the definition of. All right, let's take a look. So it says Vtac is regular, usually, right? When we're talking about monomorphic, I'm going to talk about the difference between monomorphic and polymorphic Vtac. It says it can exceed 250, right? That would be considered ventricular flutter. You won't even know the difference if you look at them. They both look like Vtac. May occasionally be slower than a 150, right? Known as slow ventricular tachycardia. It says P waves will not be preceded by P waves. Dissociated P waves can be seen. You're not going to technically know it's a P wave, okay? Because there are no P waves. It's originating in the ventricles. There's no PRI, right? We know that these QRS complexes are considered wide. All right. Vtac. This is considered monomorphic. We have two different types, monomorphic and we have polymorphic. All right. The reason why this is monomorphic is because it is the exact same every single time. We see that the rhythm doesn't change in appearance. All right. Maybe some of these beats look a little bit taller than the others, but there's very, very minute differences when looking at it. Let's take a look at this rhythm and what changes. Right. I see that we have Vtac in appearance, but it kind of like gets large and then smaller, and then it goes to almost, I don't know, like a crazy looking Vfib looking rhythm, but then it goes right back into a larger Vtac, right? We call this torsades de points, right? Twisting of the points, also known as polymorphic Vtac. Not good, by the way. Both can be seen in cardiac arrest and both can be seen with a pulse. All right. Vfib. Basically what's happening here is the ventricles are just fibrillating. They're quivering. Nothing's happening, right? This is what your AED is looking for. This is what everybody wants to shock, right? Unfortunately, not all your codes look just like this. The problem with Vfib is it doesn't allow the ventricles to fill with blood, right? That's why this rhythm is always pulseless. All right, there's no regularity, it's totally chaotic. So we look at this rhythm, this would be considered coarse Vfib. I've even seen Vfibs coarser than this, but you can really tell each wave is very discernible. So that's why we typically call it coarse or fine. Some fine Vfibs are very difficult to identify if it's fine Vfib or asystole. We'll talk a little bit about it. All right, idioventricular. We're almost at the end of the ventricular rhythms. Idioventricular, this is a rhythm that's ventricular, right? Or Purkinje fiber generated. It states 15 to 40 beats per minute. Super duper slow. This is less than 40 beats per minute. Now with what you know, the knowledge that you know of EKGs, is this going to have a P wave? The answer should be no, right? Why? Because it's coming from the ventricles. If it was coming from the atrium, right, the SA node, then there would be a P wave, right? If it was coming from the junctional rhythm, right, or the AV junction, it could have an inverted P wave, but it could also have no P wave. With ventricular rhythms, the difference is not only is there no P wave, but we also have a wide QRS complex. So we have a very, very slow rate under a rate of 40 with no P wave. That's all we're looking for, all right? Let's take a look at it. It looks like PVCs, right? Wide, bizarre QRS complexes, no P waves at a very, very slow rate. All right, under a rate of 40. Well, you can see what a big problem with idioventricular is going to be, and that is obviously cardiac output. These patients, believe it or not, has to be paced, right? This patient's going to need a pacemaker. Accelerated idioventricular. Idioventricular rhythm that is above its intrinsic rate. So it's greater than 40 to 100, because we know Vtac is greater than 100. So accelerated idio, right? When it's greater than 40 beats per minute. All right. And it's obviously just going to look just like this, but a little bit faster. Asystole. All right, asystole, also flat line, just like in the movies. All right, means the person's dead. All right, there's no firing anywhere. There's no pacemaker going off. Nothing's contracting. There is no conduction, right? No automaticity. Nothing's firing right now. Nothing's depolarizing. That is known as asystole. Now, remember, if you're having a difficult time trying to differentiate fine Vfib with asystole, some of you might even look at this and say, hey man, I see little bumps Could this still be Vfib? If you're not sure, put your monitor on AED mode, right? All monitors have an analyze function. You could always analyze, let the monitor do the decision making for you, and that monitor will tell you if shock is advised or no shock is advised. You can also increase the gain. This is now a good time that we could say, hey, let's increase the gain and see if this looks more like Vfib or is this really asystole. All right. You guys ready? Let's do it. What do you guys got here? So we have what appears to be P waves upright. We got QRS complexes. Then all of a sudden we just have P waves, or I'm sorry, wide and bizarre QRS complexes. And I see two of them on here, which makes it unifocal. So unifocal PVC. So we would consider this normal sinus rhythm with unifocal PVCs. Now, we don't see any other PVCs on this. So I don't know if this is going to be unifocal. I don't know if this is going to be poly or multifocal. I have no idea, right? But I do see that we have upright P waves. I have narrow QRS complexes. That makes this a sinus rhythm with PVC. Believe it or not the biggest deal in the world, right? The problem is when we have a lot of these PVCs in this rhythm, that's going to make it more of a problem. Classic tombstones. What are you guys calling this? Right? Remember, tombstones, they're monomorphic, right? Meaning that they are the same every single time. This is classic Vtac. Monomorphic Vtac. Why? Because it, again, is the exact same in width. Look at the width between each beat, right? It doesn't change, which makes it monomorphic, and it's super wide and complex. That's why this is considered ventricular. Monomorphic Vtac. All right. What do we got here? So we got a pattern here. We have two regular beats, and then we have a PVC that follows. All right. Remember, if it is the third beat, that is trigeminal, right? So this would be considered trigeminal. I know it up here it says unifocal PVCs. They are unifocal, right? They're the exact same, but you are 100% that this would be considered normal sinus rhythm with trigeminal PVCs. Good. What do we got here? I'm going to tell you this ain't good. So we're going to call this PVC run. This is called a run of Vtac, right? We don't call it run of PVCs. It's called run of Vtac, or it's also known as salvos. Again, we got a pattern here. They look unifocal, right? But we know that this is bigeminal because it's every other beat. Every other beat makes it bigeminal. All right, we have a rate of 40 with no P waves, wide and bizarre QRS complexes. What do we got? No, remember it's wide. Remember, if it's junctional, that means it would be a narrow QRS complex. The fact that it's wide makes it ventricular. It's at a rate of 40, which makes it idioventricular. Good. All right, we got 3 PVCs back to back. 3 PVCs back to back. Again, not good. We're seeing this again, right? Remember, if it's 3 or more PVCs in a row, that makes it a run of Vtac, or we call it salvos. You have to be able to differentiate a couplet from a run. Remember, runs of Vtac are very bad. These patients will turn into Vtac if they are not treated for it. This is the one you guys like. You shock the shit out of this guy, right? Vfib, you're right. Ventricular fibrillation. This patient needs to be defibrillated. When you get Vfib, you defib. All right, we got another pattern. Remember, when you have regular beats and then you have just a random PVC, if it comes up in a pattern, if it's every third beat, we call it trigeminal. Yep, or trigemini. Good. All right, we have what appears to be a sinus rhythm. Now, if you look at those QRS complexes, I know that they are flipped upside down. Don't let that confuse you. I know some of you in here are going to be like, hey, man, I see some elevation. There is a little bit of elevation there. Don't let that confuse you. We're not looking for that. I have an upward P wave. I have narrow QRS complexes. What we're looking for is this crazy ass premature beat there, which is a PVC, but this is normal sinus rhythm with a PVC. Good. Now this is really not good. So what we see here is this rate started with monomorphic Vtac, right? Then it turned into another rhythm, right? It turned into Vfib. So we had Vtac into Vfib. No bueno. This patient could have had a pulse and then went pulseless, right? Now be careful with this rhythm, right? And I'm going to tell you why. Some of you want to immediately say that this is, oh, well, it's bigeminal. Well, no, it's not bigeminal because we would have had PVCs here. We would have had PVCs over here on the other side, right?